Hi, everyone. Welcome to today's webinar. We are going to give a minute for everyone to get dialed in here, and we'll get started a couple minutes after the hour. Thanks for joining. People are just logging in, it looks like, so we will get started in just a minute. Okay, it looks like maybe a couple people still joining. I'll see if the number moves, and if not, we will go ahead and get started. Thank you everyone for joining today. It's a really busy time of year, so we appreciate your time and attention today. Okay, we are going to go ahead and get started. My name is Kristen McGovern. I am a partner here at Sirona Strategies. For those that don't know, Sirona is a DC-based healthcare government affairs and consulting shop. I will be joined shortly by Kristen Droback, my partner here at Sirona. I think she's having some technical difficulties, but she will join, and we will get started. We will go ahead and get started, and then she will jump in as she's able to join. Oh, there she is. She's here. Krista, we were just getting started. So the purpose of today's webinar is to just give a little preview on what Medicare Advantage will look like in 2025. As I think many people know, MA plan bids for 2025 were due back in June, and some preliminary information has already been released from CMS and from a number of Medicare Advantage plans about their expected footprint for 2025. Open enrollment has already been underway. So that process in terms of coverage and identifying the options that will be available to beneficiaries, we already have a lot of that information. And that process has really been led by the current Biden administration team under the current set of policies. Of course, in November, we had an election. We have a new team coming in with new policies and priorities. And so part of what we will do is talk about what we know will be the landscape for 2025 under the current regime, and then how we expect that the new crop of people may change policies, where they will focus, and what that will look like as we move into 2026, and how that could impact beneficiary offerings for the program. So I just wanted to provide a little bit of that level setting. We can't really talk about Medicare Advantage without talking about the political and electoral landscape, since that was a major shift that will have implications for the program. So we'll do a little bit of both here, current world, and then what we think the future world will look like. I'm going to go ahead and turn it over to Krista now to start to walk through some of the slides, and we will just tag team here. One thing that I should say as housekeeping, if you have a question, please feel free to put it in the Q&A. If we have time at the end, we will take some questions, or if we can answer questions via the chat feature, we will do that too. So please feel free to chime in with any questions as we go along here. Krista, I will turn it over to you.
Thank you, Kristen. So I'm going to go over the current landscape before we get into the preview of 2025, just for a review of what happened for this year. Medicare Advantage is more than half of Medicare beneficiaries, 67 million people, with 33 million in Medicare Advantage. Lots of seniors turning 65 every day. So obviously the program is going to grow significantly. But it was a big milestone, passing 50%, and we keep going up. Next slide. Obviously, it remains very popular. Over half of well, as we've said, half of Medicare beneficiaries are enrolled in MA. And I think we expect by 2034 that the program will be about 64%. Now that's under current regulations and law. It is possible that it could grow faster based on the interest of the Trump administration in Medicare Advantage. Next slide. So just to review what happened in 2024, it did, as far as we can tell, impact the market. The regulations plus the increase in utilization of clinical services among seniors both impacted the market. I would say that increase in utilization was somewhat expected after COVID, but might have been deeper than we expected. So these are the reforms that are underway right now. CMS began to phase in their new risk adjustment model. That removed more than 2,000 codes from the risk adjustment model. And it will be phased in, but it did already obviously have a little bit of an impact on the market. So risk adjustment is and remains a very issue of interest to CMS, and they are tackling it. The prior authorization and utilization management, CMS finalized a rule to improve and streamline prior authorization. Obviously, prior authorization has been front and center in the news the past week, but CMS has actively worked on prior auth, and Congress has legislation now that is actually could be, ready for passage. That codifies the regulations that CMS put in place. And Kristen is going to talk about 26, but in 25, CMS required that all Medicare Advantage plans establish a utilization management committee just to review their policies, recognizing that utilization management is an important part of keeping costs down. But CMS wants to make sure that we have a balance between what is appropriate and inappropriate utilization. So they required managed care organizations this year to establish those committees to review their policies. Next slide. These are some of the additional reforms that are already underway. New marketing guidelines, new guidelines around brokers, although some of those have been subject to a Loper-Bright challenge in the courts. So, but again, big effort by CMS and the Hill to tackle marketing, what is appropriate or inappropriate marketing. And so CMS is reviewing advertisements, for example, and they tried to standardize broker compensation, which was, they were sort of reversed. They had to reverse course on that given the court challenges. Data and transparency, Medicare must report on their supplemental benefits. I think that's been a question of CMS. Obviously, we want as many seniors as possible to use supplemental benefits. So CMS is interested in what those supplemental benefits look like and how each enrollee is engaging with their benefits. On quality, CMS finalized the Health Equity Index. We're obviously not sure if that is going to remain in place, probably unlikely. But the idea was to incentivize MA plans to achieve high measure scores for Medicare enrollees with social risk factors. There are very many people in minority communities and who are part of MA. But again, I think that this probably will not stand on a long-term basis. I think the incoming administration is interested in quality, but in just different ways. Okay, next slide. So as I mentioned, there has been increasing demand for services in Medicare Advantage, which I'm assuming you have seen in the news. And there is a lot of utilization pressure that is going to continue this year. I think probably that's why we have been talking about prior authorization so much, because there has been an increase and therefore an increase in utilization review. So this is expected to continue, and remains to be seen how this will impact policymaking, obviously, along with the terrible news of last week. So I'll turn it over to Kristen now for the next. I think. Oh, wait, this is my slide. As I mentioned, the impact on the market, the number of individual plan offerings did decrease in 2025. So next year there will be fewer plan offerings. You can see here the average number of MA plans per county is going up, but the overall number of plans is going down. So obviously lots of speculation about the reasons for that, but I think our feeling is that policy and utilization increases have had a role in that. Next slide, and I'll turn it over to Kristen.
So I think just tagging on to what Krista said is that while the overall top line message from CMS is that plan offerings in 2025 will remain stable, once you look under the hood of the data a little bit, it's clear that there will be disruptions in some areas. So, you know, I think that disruption is really sort of occurring like underneath the headline level. And what we are seeing is, you can see here on the left hand of the slide, is that there are a significant number of people compared to previous year whose plan was terminated or whose plan will not serve their county in the next plan year. So while the aggregate number of plan offerings might remain stable, when you really drill down into very specific geographic locations, there is significant disruption, with 7.14% of MA enrollees having to make a change or a switch in their coverage because the same plan offerings are not available to them. That is, more than double or even more than triple the disruption that we've seen in previous years. So a lot of churn, again, once you get underneath that headline level in terms of thinking about geographic specific impacts. And then on the right-hand side, you can see here that some of those beneficiaries will not have a choice of plan because there are no alternative MA plan options for them. So that is estimated to be about 500,000 MA beneficiaries will have a plan exit their county, and then they will not have an alternative option to go into next year. Sarah, next slide. Okay, great. So again, once you sort of get into a geographic assessment of the plan offerings, you can see that the number of offerings and MA plans will increase in 15 states, but decrease in 31 states. And then when you drill down even further to special needs plans sort of have the flip situation where the special needs offerings will increase in 29 states, but decrease in 7 states. So what we're seeing here is, again, even though that top line number that CMS put out remains stable, once you drill down and look at specific geographies, there is a lot of movement. So there is, in general, across more states than not, there's a decrease in the number of individual plan offerings. That the exception to that is in the special needs market, where we are actually seeing an increase in many states and special needs offering, which I think really speaks to the level of tailoring that plans are doing in terms of their offerings and thinking about specific populations and what types of coverage options might be most appropriate for them. Next slide. All right, so we've talked a little bit about coverage. Where will a plan be available? Where will an alternate be available? What types of plans will be available in terms of, a sort of a general population plan versus a special needs plan? Now we're going to talk about cost. So again, the headline here, sort of the top line, is that 2025 premiums remain generally consistent as compared to 2024. But again, same thing that we saw with coverage, there is significant statewide variation. So there are a number of states, it is a common practice in Medicare Advantage to see a $0 premium because of some of the flexibilities that plans have to reduce premiums. And so what we are seeing is, while premiums will generally remain consistent, some states will see a premium increase. Some states will see a decrease in the number of zero premium offerings, and that's even a majority of states. 32 states will not have, as many $0 options available. And we're also seeing an increase in the MOOP, the maximum out-of-pocket limit for beneficiaries increases by about $400 in 2025. So Again, while, there will be, the headline is sort of like, there's increases in some places, decreases in other places, and they net out. When you actually really drill down to figure out the impact on beneficiaries in specific states, you can see that the picture is much more nuanced in terms of affordability and costs for beneficiaries for coverage. I see there's a few questions in the chat, so we will try to get to those. Let's see. Let me just take a pause and see. Yeah, so this was back on one of the previous slides. Someone asked about for the 500,000 individuals who won't have an MA alternative due to the plan leaving the market, still no protection for them from falling into the Medigap trap. Yeah, so the option for those folks that do not have, whose plan exited the market and for whom there is no other plan option, those people would revert to fee-for-service. And as is the practice in fee-for-service, most fee-for-service beneficiaries then get supplemental coverage, and so that would be the alternative for those individuals, would be fee-for-service with supplemental coverage. All right, let's go ahead and go to the next slide. In terms of supplemental benefits, so this is one thing that is different about Medicare Advantage from fee-for-service, which is that Medicare Advantage plans are required to offer the same core benefits that Medicare fee-for-service beneficiaries receive, but they also have some flexibility to offer supplemental benefits, either paid for from rebate dollars or out of their own out-of-pocket costs. Offering supplemental benefits has been is a widespread common practice for all MA plans. And so the most common supplemental benefits are vision, hearing, and dental. You can see that most plans will continue to offer vision, hearing, and dental in 2025. We're at like 97 to 99% of plans offer those core set of supplemental benefits. And then there are plans that are making choices with respect to the additional supplemental benefits that they choose to offer. So some of these supplemental benefits, like the fitness benefit or an over-the-counter pharmacy benefit, meals, remote access technologies, non-emergency medical transportation, those benefits are declining. And then there are also other benefits that we're seeing a decline. So in-home support services, caregiver support, and adult day and health services. I think the top line coming out of CMS was that supplemental benefits are stable. But when you look at the underlying data point, I think what we are hearing from the plans and seeing from the plans is that, just taking meals, for example, or transportation, yes, they may still be offering a transportation benefit, but maybe in some places they're offering like 4 free rides instead of 6 free rides, or otherwise reducing the monetary value of that benefit, even as they may be lifting it from that, continuing to offer it as. So we are sort of seeing, again, once you look under the hood, the granular picture becomes, a little bit different than the headline in terms of thinking about these additional benefits that are being offered. Again, either by plans paid through rebate dollars that they receive from the government or from their own discretionary funds. This is additional detail on the supplemental benefit slide. I won't go into this in more detail, but you can sort of see that over time, some of these offerings have, we sort of had a spike from 2020, 2021, 2022, where there were to 2023 even, where there were a consistent climb in the number of plans offering some of these supplemental benefits. And then, we saw that basically plateau in 2024 and then decrease in 2025. I think there's two schools of thinking on these supplemental benefits. One is that we don't maybe we don't need to continue to see an exponential increase in the amount of supplemental benefits offered to Medicare Advantage employees. So the plateau and or slight decrease is okay. But then the other school of thinking is that the plateau means Medicare Advantage is continuing to grow in terms of the proportion of Medicare Advantage or Medicare beneficiaries that are enrolled. So, the absolute numbers can't really be compared because proportionally it represents a smaller amount of beneficiaries receiving access to these benefits. So just because you see here, you might see 5,700 and think that looks pretty similar to 5,600 in terms of the number of plans offering benefits. But the thing to keep in mind is that greater numbers of Medicare enrollees are enrolling in Medicare Advantage. And so proportionally, the number is much smaller, even though the absolute number looks very similar. Okay, so where are we in the rulemaking process and what does the timeline look like? So I mentioned that everything that we just talked about with respect to 2025 in terms of coverage and benefits and affordability, all of that was set in stone through the annual process that occurs over the summer. And really under the current set of rules from the Biden administration. So you can sort of see here a general annual timeline. We right now are in the 2026 rulemaking process. So CMS released a proposed technical rule, which would have some updates for, which would need to be finalized and would have some updates for 2026. That rule, the comment deadline is January 27th. So that rule, the comments on that rule will be, we're in a little bit of a weird zone where the Biden administration will have developed the policy and put out the proposed rule, but a Trump administration will review the comments and decide what, if anything, they want to move forward on for 2026. And we can talk a little bit about that rulemaking. The second piece of rulemaking that is in progress is the advance notice, which is a sub-regulatory document that is put out for 30 days for public comment. It is generally, has the rates and the additional detail around payment and how and what MA plans will be paid for and what CMS will expect. So that generally comes out, first week in February and proposed and is finalized first week in April. There have been some questions this year about whether the timeline will hold or what the timeline will look like given a change in administration. I think no matter what, the policy making there is well underway with the current career staff and political team at CMS. And so the question will be, when does the Trump team get in there and how much time do they have to make an impact on the proposed advance notice? So we are sort of mid-flight here. And again, we would all hope maybe that everything could be tied up with a bow and one administration would propose and finalize and wrap it up, and then the next administration would move forward. But that will not be the case here with the 2026 rulemaking. We will have proposals from one administration and policies finalized by the next administration. So that will make things a little bit turbulent in this space as we think about policies for 2026. So I mentioned that the Biden administration put out their proposed rule for Medicare Advantage for 2026. Comments will be due January 27th. Rule will be finalized by the Trump administration. You can see here on this slide all of the categories of proposals made by the Biden administration. By far, the most significant proposal included in the proposed rule is the proposal to cover GLP-1s for obesity for Medicare and Medicaid patients. That proposal is estimated to cost about $24 billion. It is a reversal of previous Biden administration policy that obesity, was not a, chronic disease that fit the definition such that the drug should be covered. They're now proposing to do that. We have seen surrogates for the new incoming political team speaking out about this proposal on social media, and in particular expressing concern around, moving right to a pharmaceutical intervention rather than treating the underlying causes for obesity. So if the current folks are confirmed, we would anticipate that they might want to take a look at this policy and decide if this is how they want to spend $24 billion, or if they do not want to do this, or if they want to do something else. So that is sort of the hot button proposal that was included in this rule. There are a number of other things that were proposed here that may not be a priority for a Trump administration and that we will need to look at to see sort of how they would move forward on some of these. So for example, with respect to utilization management, they proposed line item reporting on the annual health equity analysis for utilization management, which is sort of a term of art that includes prior authorization. So how are you deploying your prior authorization policies in an equitable way? Give us more detail on that. A Trump administration may not be interested in that to the level of a Biden administration. Another example is on brokers. So Krista mentioned that the Biden administration took sort of a big swing at brokers in terms of setting restrictions on the fees that they could receive for counseling individuals with respect to their coverage options. Those restrictions were struck down as a result of legal challenge. They did not in this rule propose again to restrict the fees that brokers could receive, but they did propose a new list of topics that brokers need to discuss with patients that they are mandated to discuss. They have proposed things here, like that there should be a pause, they should address certain topics and then pause to let the individual respond. So there's obviously a lot of specificity here in terms of scripting what these conversations should look like. And again, unclear, whether that is something that a Trump administration would be interested in moving forward, or if they would think that there should be a different list of things, a shorter list of things, more flexibility. We will really be looking to see what they think about some of those issues. And then I'm not going to go through all of these things, but another policy here that is fairly important is the policy with respect to internal coverage criteria. So this proposed rule provision is pretty important, I think, to many MA plans. They are required currently to post their internal coverage criteria on their website. And this proposed rule would include additional, restrictions on whether you can require a person to input their email or any password or, code or anything like that to get access to those criteria. So the rule would propose that those restrictions should not be in place and that the coverage criteria should be freely available. The plans, of course, say that there are risks to IP, associated with making some of this information available. So sort of TBD on whether and how prescriptive a Trump administration would want to be with respect to some of these issues, or whether they would be sympathetic to concerns around intellectual property and other sort of proprietary products for health plans. So that's just a flavor. There are two sides to all of these things. As the Trump administration comes in, they will be going through confirmation hearings. And we have listed here just sort of, there's many people throughout HHS who need to be confirmed. And, there will be opportunity for them to share their thoughts on Medicare Advantage overall, at least those that are responsible for Medicare Advantage, in particular, the nominee for HHS secretary, and then the nominee for CMS administrator. But all of these folks require confirmation, and Congress will be very busy on that in January next year. Krista, should I turn it over to you now to talk about RFK?
Yep. Okay, so wanted to talk about the top officials. We do not yet know who is going to be in charge of Medicare or Medicaid sort of at the deputy level, but we do have obviously know HHS and CMS. And as I'm sure you've heard, Robert Kennedy Jr. is the nominee for HHS. He is very interested in a plan called Make America Healthy Again, which is really focused in on chronic disease prevention and has sort of outlined ideas for getting at the root cause of chronic disease instead of focusing in on the clinical aspects of healthcare. So that includes, food and nutrition, that obviously would lend itself more to MA than fee for service, given the flexibility and supplemental benefits that are available in Medicare Advantage. But from what we can tell, he's going to leave a lot of the day-to-day and vision for Medicare and Medicaid to Dr. Oz, who is nominated to be the head of CMS. He is a surgeon and has been a major champion of Medicare Advantage. He's advocated for Medicare Advantage for all. And that is not all Americans, but all seniors. So I think he is going to want to make a push into Medicare Advantage. And he's already sort of behind the scenes asking questions and talking to people about Medicare Advantage versus fee for service. He's expressed support in value-based care, telehealth, AI, remote monitoring. He has investments in some companies that are digital health and other things that will be probably top of mind for him as he comes in. But I think this headline sums it up well, that Dr. Oz is an ally to the program. Next slide. At the same time, we have sort of an overall interest by the Trump administration in cutting the size and the funding of government. And so they have set up the Department of Government Efficiency, DOGE. It is not a actual government department, but it is going to be making recommendations to the Trump administration. There has been hesitation by President Trump to touch Medicare or Social Security, and according to reports, the DOGE is not looking deeply at Medicare and Social Security, but the level of cuts that they want to make is pretty significant and will be difficult to do without addressing Medicare and Social Security in some way. And House Republicans did open the door to those cuts last week, but it remains to be seen. Medicaid and the marketplaces are definitely on the table, but it's unclear yet if Medicare will be part of that discussion. They will be making their recommendation. They are already behind the scenes making recommendations on what to cut, and you can tune in and hear what they're working on with their Dogecast, which is a public podcast on the recommendations that they're be making. One other thing, they do have people inside government agencies, and the person has already been assigned to CMS that will be working with them to figure out what regulations can be rolled back and what funding might not be necessary, and what office or positions in the civil service might not be necessary. The next slide. There's also something called Schedule F, which is essentially creates a new class of political appointee, and they want to move about 50,000 career civil servants into the political appointee status, which then would allow them to essentially fire people and will help them achieve their goal of reducing the federal workforce. This is already causing ripple effects. I think the three things that are really causing ripple sort of concern among the federal workforce is, number one, back to work mandates. So back to the office. Lots of people moved. So, I think there will be some reduction in workforce based on people who don't want to move back to Baltimore. The second is Schedule F. And the third is retirements. About 30% of CMS is eligible for retirement, and it remains to be seen kind of how many of those people will want to stay. So we do expect there to be a reduction in the number of people at CMS who will be working on Medicare Advantage and overall just the whole department. So it might be more difficult to bring data or evidence or get meetings there. And so it might have some impact on the ability to, to really make your case about particular aspects of Medicare Advantage, but obviously we don't know yet. It's just something to look out for. So our overall expectations for the next Trump administration are that there will continue to be interest in risk adjustment reforms. And that has been bipartisan. We encourage you to read the Paragon reports. The Paragon Institute is many former Trump officials who have written papers um, on other, many things related to Medicare Advantage, risk adjustment being one of them. So expect that that will not be likely to go away. There's an expectation that that there will be more support for expanding and increasing the flexibility around supplemental benefits, given the sort of whole person approach that the incoming group of leaders at CMS and HHS have. Supplemental benefits is a good way to influence policy around food, and housing and other areas that they think contribute to chronic disease. Unlikely to see major changes in star ratings other than rolling back some of the health equity index. And also there could be some action related to the lawsuits that we saw. There were at least 3 where health plans asked that their ratings be recalculated. And that happened. So obviously there will be some examination of that. Enrollment, there is ways for them to increase enrollment in Medicare Advantage through like default enrollment, for example. So if they're really serious about expanding the Medicare Advantage program, they could look at some of those. And then on fee for service, we want to align the program rules as much as possible, and that fits with the philosophy of simplicity and lower, regulation in government. And then finally, value-based care. We're expecting that the interest in value-based care will continue. And so I think we expect that CMMI will continue. And so expectation again is that we'll continue with value-based care. Kristen, question. In anticipation of the Trump administration, could they change any of the 2025 rules? And they would have to, well, you go ahead and answer.
So the 2025 rules will go into effect on January, or go into effect or stay in effect for January 1, 2025. They could come in and change them on a go forward basis or not force them in some ways, but we won't know that until after they come into office. So anything that is currently in place or is expected to go into place January 1, 2025 will go in, and then we will see what they do when they get there. Okay, are there ways they can do MA as a default without legislation? Yes, I think so.
Yeah, there's a way that they could basically default people into a plan based on the plan that they have in the commercial market when they turn 65. So if you have a particular plan and you turn 65 and you don't opt into anything, then you could be defaulted into a plan that you already have. So the issuer would be the same essentially.
Any other questions to add into the chat? All right, one other thing I think to note is that, in terms of the positions of the current or the nominees, we will learn a lot. I think as we mentioned during their confirmation hearings, we are expecting Medicare Advantage will come up during their confirmation hearings. One thing to note is that Dr. Oz in particular has been vocal about sort of a concept around Medicare Advantage for all, which is this default idea. It could there are a lot of ways that could be implemented. Right now we have a system where MA plans sort of like bid, and then CMS, approves those bids or like goes back and forth with the plans on the bids. We could have it could look very different. So support for MA is not like homogenous one size fits all kind of thing. Definitely how it could be implemented. I think there are a lot of different ways that they could go with trying to encourage MA as the default option. And that could mean a lot of plan choices. It could mean a few MA plan choices or a single MA plan choice. There's a lot of variation here in terms of what that could look like. We did get one other question, and let me, I will just tee this one up. So, question is, will Medicare Advantage be a priority for Congress in 2025? What activity, if any, can we expect? So we've talked about the administration folks. We did not talk as much about Congress, but it is expected that Medicare Advantage will continue to be an interest for congressional leadership. Krista mentioned on one of the slides that there's bipartisan interest in some risk adjustment policies. We expect that that will continue, even as congressional leaders have said that there won't be much bipartisan activity. We do expect that there will be some pockets of bipartisan activity. I think that these things will be, not front and center in terms of, policy reform, although Congress has a lot of things that they want to do that cost money next year. And so Medicare Advantage is generally talked about as a possible pay for. There are some policies out there like increasing the statutory minimum coding intensity adjustment or other things that are sort of always on the list of things that are talked about as a pay for. TBD on whether a Republican controlled Congress would be interested in using any of those pay fors, even though we know that there is some targeted interest in some of these other policy issues. So we do expect congressional activity, but we don't expect, for example, a Medicare Advantage overhaul, bill or anything like that. Okay, and then we have one more question, and that is, as supplemental benefits offerings grow, including those addressing health-related social needs, do you see increased opportunities for partnership between MA plans and community-based organizations or other external stakeholders? Krista, I will let you maybe talk about social needs in terms of what you think this administration or Congress will do on social needs.
I think that it will be more based on chronic disease. So that is the sort of the new umbrella of the way that we look at things rather than social drivers. So I think, if you listen to RFK Jr., he talks about food, a lot of food and walkable communities and, are you out in the sunshine? Like he talks about whole person well-being, but it's couched in the terms of chronic disease and the drivers of chronic disease, not necessarily the way we talk about in the past have talked about social drivers of health. So I think that the extent to which they look at supplemental benefits, it will be what is getting at those root causes. So food as medicine will likely be front and center, although it might not be called food as medicine. So to the extent that you are working or want to work with MA plans on sort of whole person, healthier environment, healthier food type of projects, I think that would be something that the administration would look very favorable upon.
Okay, one more question. When is the Doge podcast starting? And is there a name for the podcast? So Vivek Ramaswamy, who is Elon Musk's co-partner in crime here, on Doge announced he has his own podcast, his personal podcast. He announced he would be putting that on hiatus because they will be spinning up this new podcast. It's called Dogecast, is what he called it. It does not appear, I just checked my podcast player. It doesn't appear to have a show landing page yet. And I don't know if we know the date for it yet. Although they have announced, that they're putting or at least Vivek is putting his personal podcast on hold to do this other podcast. So it doesn't appear to be live yet. And I don't know that we have a date, but I think they are very active on social media. And so that is probably how they will announce it to start. Okay. Okay, we are at time. Thank you for joining. I know we have one other question about the slides and whether the slides will be available Yes, we can make the slides available. We also recorded the webinar, so we will send out the webinar recording to everyone that was registered after today's webinar. You see our contact information here on the slide, or you see our names at least. So hopefully you know how to find us. We know how to find you. So we will send our contact information along in the follow-up email when we send the recording to the website or the webinar itself. So thank you for joining us. Krista,
Thank you.
anything to add? Nope. Okay. Thank you.